unfortunately. But they didn't make it to the vet. The wife started coughing up blood on the way to the emerge, or way to the vet, so they decided to reroute to the adult human emerge. She had been complaining of 3 days of fever, muscle aches, mostly in the calves and the back, and nausea. So she didn't think too much of it initially, had some mild upper abdominal pain. She had vomiting yesterday, but again, so let's just wait this out. Lasted for 5 days and seemed to go away, so she thought she was in the clear and maybe got a virus. She developed a headache. She attended a walk-in clinic to get verification this was an upper respiratory tract infection perhaps, and to treat it conservatively. A few days later, the symptoms returned. Of note, she has no past medical history, no meds, no allergies. They had a couple and their dog were recently camping, canoeing, or kayaking in northern Canada 3 weeks ago. Oh, the weeks is blurred out. 3 weeks ago. So enter the kayaking, enter the travel history. Vitals are as follows. Hypotensive, tachycardic, febrile, decreased saturations. Looks unwell. Not a lot to find on cardiac exam, but fine crackles on respiratory exam. Abdominal pain with splenomegaly, no hepatomegaly, normal bowel sounds. Bleeding gums, see normal pharyngeal tissue, normal ears, no lymphadenopathy. Conjunctiva are injected but not inflamed, which is an important feature I think that Meg picked out. They appear to be red and yellow. So there's red spots to the sclera and yellow spots to the sclera, which is a little odd. The neuro exam is pretty normal. That's there. Blood work, as you can see. I won't go through the whole thing, just let you look for a second. ECG is fairly normal, sinus tachycardia, nothing in the urine. Chest X-ray has bilateral infiltrates, kind of patchy. Blood cultures are bending. Enter Dr. Garnett, who happens to be working at this time. She already knows the diagnosis, hearing all of this, obviously. So she admits this patient to hospital for treatment. So, bring up Meg.
Thank you. All right. Thanks for coming this morning. I've been looking forward to doing this for a year and a half when my CPC got canceled last year, and I did give Dave very strict criteria for what I wanted my case to involve. So I'll begin by talking of some of the perils of kayaking in Canada, because that's what you're here to hear about. So there's many dangerous parts of kayaking. I mean, there's difficult launches, difficult landing zones. You sometimes have to contend with waves. There's high winds, gale force winds. Sometimes you have to contend with current. And then there's always the occasional ice flow. But this case is a case of a different peril in kayaking, and I'll just go through the case very quickly to give you my thoughts on it and then present you my differential. So Dave presented this case as wife feeling unwell, they're going to bring their dog to the vet, but instead they had to go to the emerge because she was feeling unwell. And when I read this initially, my thought was, uh-oh, I hope the dog's okay. But then on second thought, I thought, okay, so this is a case of flu-like symptoms plus hemoptysis. And the case goes on, and he talks about all of these prodromal symptoms that she'd had earlier, and she'd gone to a walk-in, and they told her it was a URTI and that she should have rest and fluids. And I thought, I cannot believe the walk-in clinic told her she had a cold. Then the case goes on to say she's healthy, and that my case said that she'd been in Northern Ontario, not Northern Canada, and that they just recently returned from a kayaking trip with their dog. And I thought, well, how did they bring their dog on the kayaking trip? Because, Dr. Ouellette, this is a kayak. You can see in a kayak, there are bow and stern hatches. They need to be watertight for the kayak to stay above the water. So you can't open them and put your dog in it because you will submerge. There is also a cockpit to the kayak, and that has a skirt on it, so you can't put your dog there. This is a canoe. you can see that you can fit children and dogs into canoes. So then I thought in my case, well, there's one of two possibilities. Either she lied about bringing her dog on the trip, or for the 50th time since I started residency, Dr. Roulette has confused a kayak and a canoe. And I'm going with the latter. Easily confused. So then I got her vital signs, and I thought, okay, well, at least her glucose is normal. And then the physical exam, and if you go through all, I mean, she's got lots of different findings on physical. None of them are really that specific, but I thought, oh, maybe I should consult dermatology for the bruising. And then finally, the investigations. I've highlighted one lab abnormality, the platelets there. But there's, I mean, she's got renal failure. She's got a little bit of rhabdo. She's a little bit acidotic. Her urinalysis isn't normal. It shows mild protein. And otherwise, there's not really anything specific in those tests. And my first thought when I received that was, you have 25 loads of platelets and you didn't give me a beta. That is cruel. So those were my initial thoughts. The next thing I did after I got this case was I asked my husband, well, what are your thoughts? He isn't medically trained. He's an aircraft mechanic, but he knows a lot about kayaking, he knows a lot about dogs, and he knows a lot about Northern Ontario. So I read him the case, and in about 5 minutes, this was the differential that spewed out of his mouth. And I was a little upset because I've been studying for a long time. And then this 5 minutes took him to come up with this list. And I thought, that is not right. But Dave probably didn't know that I had help at home. So the next thing I thought, okay, like that's my husband's differential, it's very good. But I need to keep a very open mind. I know that this sounds like an infection, like my gut instinct tells me she has an infection of some sort, but there's a lot of things it could be. She's really sick, so I need to think of all the big categories. So while I think it's probably infectious, I'm going to consider some diagnoses in other categories, and maybe I'll be surprised at the answer. So what I decided to do is I took something from the history, something from the physical, and something from the investigations, and then I thought, if I can pick one feature of each and tie it into Northern Ontario or kayaking or being related to the dog somehow, I would come up with a really great diagnosis if I could find something that kind of sits in the center here. So that's what I did. So she's a 28-year-old healthy female, so I took all the causes of hemoptysis that you could have in a 28-year-old female in Canada who has no underlying medical problems. And then if you take in the fever from either infectious causes or just other broad categories like fever or hyperthermia, you can take this list and essentially cross out anything that doesn't have fever, and you're left with this list. And then if you take that list and you take out anything that doesn't have thrombocytopenia, you're essentially left with this list. So this is my differential. High on the list are infectious causes and other like serious causes of infection, like sepsis-like entities. I thought PE should go on the differential. For toxins, I thought the most likely toxin that fit her picture would be elemental mercury. For a vasculitis, I thought Wagner's fit. An autoimmune disorder, I thought lupus. Platelet disorders, TGP. And then maybe she has like a new diagnosis of cancer or metastatic disease. And then if I've forgotten something on the list, it's caught by the last one, which is just any severe illness resulting in ARDS or DIC. Of note, she doesn't have diarrhea. She doesn't have lymphadenopathy. She doesn't have hematuria, anemia, and I did ask, and she's not pregnant. So this is very helpful when I'm trying to come up with a list of particularly infectious causes. So I'm just going to go through some of the non-infectious things that I thought it could be and just kind of give you some evidence for or against those diagnoses. So PE, I mean, it had to cross everybody's mind, right? Because she's tachycardic, she's hypoxic, she's tachypnic, she's hypotensive, she's coughing up blood. She recently had a long car ride probably to get to Northern Ontario, and she's been sitting in her kayak. She even has calf pain, and she probably forgot to tell me about her birth control pill. But then against that is that she's young and healthy and she doesn't have any medical history, so it'd be kind of weird. It was kind of a biphasic illness that she presented with, so PE doesn't usually, get bad and get better and get bad again. And then there's other kind of systems that are involved that you don't typically see in PE. In terms of mercury toxicity for a toxin, her symptoms are respiratory, so that fits with like an elemental mercury exposure. However, you'd think if, like in Northern Ontario, if you're going and we think of, mercury toxicity in Northern Ontario, it's usually organic from ingestion of fish. So while her symptoms sound maybe more elemental, her exposure in Northern Ontario is probably organic. And probably the most famous case of this in Northern Ontario is from the 1970s from the Dryden Chemical Company when they're making products for the Dryden Pulp and Paper Mill. They released over 9,000 kilograms of organic mercury into the Wabigoon English River, and it affected 2 First Nations right at kind of the northwest border near the Manitoba border, Grassy Narrows and White Dog. But again, these people presented with neurologic disease. Well, I mean, she's thrombocytopenic, but my gosh, she's missing the microangiopathic hemolytic anemia that you need almost to diagnose TTP. Other than that, she's got most of the penta that we think of. She's got the low platelets, she's got renal insufficiency, she's got fever, and some people consider headache kind of part of that altered mental status. So you could almost say she has everything, but she's missing that key anemia. So those were the things that I thought of for non-infectious causes of her presentation. But what I'm more interested in are the infectious causes. So what I did was made a list of viral causes, bacterial, fungal, and parasitic that could happen in a healthy female in Canada. So there are no tropical, like diseases that are confined to the tropics aren't on this list. And what I am going to do is go through the 5 top infections that I think it could be. And then one of those 5 will be the one that I've settled on as being the cause of her symptoms. So number 1 is hantavirus, and specifically hantavirus pulmonary syndrome. It's you get hantavirus, like it doesn't often cause. The clinical definition for this disease is a temperature greater than 38.3. So yes, she has that. Some changes on her chest X-ray that could be consistent with ARDS, and she maybe is developing that. Respiratory compromise, needing O2 within 72 hours of hospital admission, which I would say she's probably on her way to needing O2, and she's previously healthy. This disease presents with a prodromal phase like she had, lasting 2 to 8 days, and they get like almost all the symptoms that she has: fever, myalgia often in the back and legs, and some other constitutional symptoms. But interestingly, URTI symptoms like the pharyngitis that she had are notably absent from this disease. And the South American equivalent of our North American virus can cause the conjunctivitis and the petechiae, but not the sim nombre virus that we see in North America, so the eye symptoms don't really fit. When you make it past the prodromal phase, you go into a cardiopulmonary phase, and it's heralded by the onset of cough, and then you get sick fast. And if you did some blood work on these people, you'd see a leukocytosis, which she had, and a rapid decline in platelet counts. However, I don't have an LDH, a lactate, an albumin, or a hematocrit, but for the labs that I did get, they are all consistent with this illness. So that's hantavirus pulmonary syndrome, and it's the first of the 5 infectious causes I think it could be. The next is tuberculosis. I have to think about it because it's in Northern Ontario. And we are an Aboriginal community. Her chest X-ray is abnormal, but TB can have a wide range of manifestations on a chest X-ray. And I think it's important to be on a Northern Ontario differential because landscapers, farmers, and people who own these animals as a pet. I think there was a case from Manitoba last year, some rodent or something that got shipped down to Minnesota, and the animal tested positive for it. So we do still have it in Canada. It's just not very common. Its average incubation period is 3 to 5 days, so it's a little more virulent. So it's shorter incubation period and maybe doesn't quite fit with how long it took her to develop symptoms. It is a reportable condition to the Middlesex London Health Unit, and dogs can get it, just like general tularemia, not necessarily pneumonic tularemia, and they can transmit it to humans. There are 6 forms of it, and it's the pneumonic kind because she has the respiratory symptoms that would be most consistent with an atypical pneumonia. You can get a minimally productive cough, and you can go on to develop severe pneumonia and life-threatening illness. Investigations are largely unhelpful. You have to really have a clinical suspicion of this disease to probably catch on to it. But I mean, if like very basic things like a white count, elevated liver enzymes, and an elevated CK. So that's disease number 3. Disease number 4 is blastomycosis. You knew I was going to talk about it if we're talking about Northern Ontario and pneumonia. So it's a fungus. We get it by inhaling spores that are in like decaying organic material in the soil. It's found in North America and specifically found in the Great Lakes basins, the Canadian Shield, and in the St. Lawrence Seaway. It affects healthy people and it does affect campers or like tree planters, forestry workers. It has a longer incubation period than her presentation. It's not a reportable disease and dogs can get it, but they can't transmit it to humans. This is a map of where blasto is endemic in North America. You can see the northwestern Ontario up here, and then I'm pretty sure London is in this area somewhere, so we're like not safe from it. And it's typically in Northern Ontario, we think of it in kind of the Kenora area, like Winnipeg's, Muskoka or Cottage country. They can present with a self-limiting flu-like illness and acute pneumonia, just like she did, and they can be rapidly get worse. And up to a quarter of the cases can present with hemoptysis. There's some extrapulmonary symptoms, though, that she doesn't really have, like the skin lesions, osteolytic lesions, endometritis. And I mean, she has a normal neurologic exam and CNS involvement is rare. If you were to do investigations on this patient, you would see a leukocytosis. Your blood work would otherwise be largely unhelpful. And your chest x-ray, again, can have a wide variety of patterns to it and perhaps could be consistent with her chest x-ray. It's a very non-specific chest x-ray that she has. So that's disease 4. The last one is leptospirosis, disease number 5. So this is a bacterial infection. You get it from being exposed to contaminated water or soil from rodent urine. And it either come, like you get it through cuts, like exposed skin, or you can get it through mucous membranes as well. It's a disease that's found not only in Canada, but throughout the world, and it's a lot more prevalent in the tropics. Of note, it's the vaccine that we use in Canada for dogs, though, covers the most common strains, but not necessarily the most severe strains. The acute phase lasts 5 to 7 days, and you get fever, myalgias, typically in your calves and your back, and a few like other non-specific constitutional symptoms. It's a biphasic illness, and you can have a period of convalescence before you get sick again, and recurrence of the disease or the second stage is marked by the onset of fever. Most people get it, and they don't go on to that second stage. They don't know why, but some people go on and develop more severe illness. So the second phase, you get fever and your myalgias return, you get a headache, and they often have meningitis. They can have hepatosplenomegaly and jaundice, and they can go on to develop pulmonary hemorrhaging and ARDS, as well as subconjunctival hemorrhaging. If you did blood work on these people, you would find a leukocytosis and the thrombocytopenia, a mild transaminitis under 200, and your bilirubin kind of reaches this 60 to 80 level, but doesn't go any higher. Then there's a more severe form of lepto called Wheals disease, and it's basically icteric leptospirosis, and it carries a higher mortality rate at 10%. You get fever, jaundice, renal failure, and hemorrhage. And as I was thinking about this disease, I thought, oh, okay, where have we come in contact with lepto before? And last year, my husband and I were hiking one of the trails in Hawaii. We came across this sign that warned us before going on the trail that the fresh water was contaminated with leptospirosis. And one of the key features of this disease is this conjunctival suffusion. So patients get redness of the conjunctiva that looks like conjunctivitis, but the part that's different is that there's no leakage of inflammatory fluid. They just get redness. And then on top of that, they get the scleral icterus. So with that in mind, after thinking about this case for a week, I have come to the conclusion that I think my patient has Wheals disease or leptospirosis. That is all.
that case? Is that when you were in ICU or something?
This was with one of her colleagues here. I don't know if she saw it at another facility or here, but it was one of our colleagues that saw it through the emerge, apparently. So great job, Meg. Awesome job. And she put up this sign, and when I first sent her the case, about 31 seconds later, she sent me back an email. I don't know if it was Lyle or her, but somebody sent me an email from her house with this picture in it. So hopefully I made it hard enough for you and more and enjoyable, and hopefully everybody else enjoyed the case. I always find it interesting every time I talk to the residents about their thought process for the case, leading up to the case, and everyone does something different every time so far, which is really interesting. With Meg's Venn diagram, picking out the highest differential in each one of the categories and pooling those and using the infections. So that's always really, really interesting to me. You might argue, though, that Meg had the ultimate strategy, which I alluded to before. She basically planted the case in my head a year and a half ago and made me present the exact case that she wanted. So that might be the best strategy that's ever happened for CPC. And not that I'm influenceable at all in any way, which is sad. So great job, Meg. Does anybody have any questions or comments before we move on to the next case?
Treatment?
Andy.
It's penicillin or doxycycline.
And supportive care if they're that sick.
Yeah, it's very...
Questions or comments? So next case, keeping on the theme of Ontario and camping in cottages, is the perils of buying a cottage. Another real case that a colleague of mine saw, not in London. This is Dr. Chris Lee, who's involved in this case. I'll give you the basic summary. 14-month-old baby. He would have hated me when he received this case, I think. But sorry, Chris, 14-month-old, brought in by the parents that they're concerned. The child was walking and no longer is walking. Appears withdrawn and uninterested in life. Had some gum bleeding with mouth care. The gums were swollen, erythematous, with some erosions. The symptoms began 4 weeks ago with some irritability, some fatigue, fever, and then visited the family doctor. Family doctor said, you know what, this is probably viral. Why don't we treat it conservatively, rest in fluids, see if it gets better. 2 weeks go by, this child's symptoms sort of continue. They're not getting better, they're not getting worse. He then starts to develop erythema on the fingers and toes, decreased appetite, back to the family doctor. Actually, the family doctor does a workup with blood work, urine tests, and apparently we don't have the investigations, unfortunately, but they were normal, and the family doctor thought, well, let's just watch this a little bit longer. I don't see too many red flags, and see how this goes. Of note, thereafter, the parents noticed that the child would sweat quite often, even during normal activity. The intermittent fevers continued. Appetite was still decreased. There was 2.5 at least pounds of weight loss, which is a lot for a 14-month-old who should not be losing any weight at all. The child's hands and feet were continuing to be swollen and progressing up to hands and the wrist. Of note, the couple has moved to their new cottage around the Timmins area, but they've had no travel outside of Ontario. Physical exam, everything is pretty normal for birth and pregnancy. Social development was normal up until 4 weeks ago, until the regression. No past medical history, meds or allergies. Immunizations up to date. So we've got a really healthy child here. Family history of depression, anxiety, schizophrenia. I'm not sure if a 14-month-old can have schizophrenia, but there's the mental health history should you need it. The child is irritable, he's afraid, he's crying through the whole exam, he's very, very irritable. The vitals, as you can see, he's hypertensive, tachycardic, not febrile at the moment, with good sats. You don't find anything on cardio-resp abdominal exam, but you do find the swollen gums, a few mouth sores, no lymphadenopathy, the ears are good, the throat is good. CNS, you find him photophobic, the child, not cooperative in any way, but you do manage to get most of your stuff done, and it's pretty normal, except for the gait. And so the child refused to walk, but you know that they can sort of stand up because you kind of noticed it during your exam, but they refused to walk. Derm, so hands and feet, you do know that they are swollen up to the wrists and red and erythematous. Even the wrists and ankles, or even the ankles and feet are, they started to peel. out at the fingertips, up towards the hand. You do notice a faint maculopapular truncal rash and a fine tremor on exam when you're examining the child. Lab work. I'll leave it up there if you look at briefly. Urine is pretty clear. ECG is sinus and appropriate for age, all the criteria. And enter Dr. Lee, who has a good idea what's going on already. He's got one investigation really to sort out what's going on. So good luck.
Hi everyone, I'm just going to switch over computers here, forgive me. All right, so everyone knows that Meg knows something about kayaking, and this is the reason that Dave gave her that case, but you may not know that I obviously know lots about purchasing a new cottage. I have multiple properties. This is my newest one in Tobermory, and my favorite one is actually in New Zealand, this one here. I go here all the time. If you don't believe me, that's a picture of me in my cottage there in New Zealand. We have friends that come over all the time. We go hiking. I think this time we went up to a mountain. We went there and back. It was great. So I have lots of experience. So this is my case. Dave went through it already, so I'm not going to belabor the points. These are the main things that kind of jumped out at me in terms of the history and physical things in the case that were likely going to lead me to a diagnosis. And as you know, the labs and, the physical exam and history, past medical history is really non-contributory. There's some abnormalities in the vital signs. It's hypertensive and tachycardic. And the child is very irritable and afraid, which is not what baseline is as per mom. Dave went through the physical examination already. So I'll just summarize it here. So these are the things from the case I took as major signals that I could look at to develop a differential diagnosis and finally come to my answer at the end. The major ones, my strategy was, okay, I'll get the case and I'll see if I have any idea what it is. And I looked at it and I said, I have no idea what this is. And then so I said, okay, well, let me pick out the major things and develop a differential diagnosis amongst all of these things I've highlighted. And if there's anything in common, then I can make a more summarized differential and then pick out my final diagnosis. But just to start, I wanted to get a kind of a sense in terms of major categories of what I thought this might be. So I looked at the irritable, tired, uninterested. I know that's a huge differential for a child. But I thought, if there's a change from baseline in neurological status, if that happens at any time, I think about my I-watch death mnemonic, which is for delirium. And so just for major categories, this is what I went with. So could it be infectious? For sure. 14-month-old, I didn't think there's any withdrawal history there. Metabolic, definitely. We didn't get a traumatic history, so I'm taking that off. CNS pathology, focal CNS pathology is unlikely to cause all those systemic manifestations that we saw. And hypoxia itself, yes, can definitely make neurological changes, but not the systemic manifestations. And the rest of them, deficiencies, endocrine abnormalities, vascular, toxins, and heavy metals for sure. So at the end of the day, what I'm really looking at is a systemic illness. And that just helped me to crystallize, the diagnosis is probably in one of these categories. Okay, so let's start with gross motor regression. And when I look at gross motor regression, I think about it in two ways. Like when we're seeing our weakened dizzies in the emerge, I think, okay, are you just so tired that you can't actually walk? Or is there actually something, are you actually weak, like neurologically weak? And when you think about the differential diagnosis fatigue, it's huge. And when I saw that list, I said, okay, I'm just going to ignore that and not look at it anymore. So I went down organic neurology, and for a child to regress in their motor function, it has to be either something's wrong with sensation, there's a cerebellar defect, basal ganglia is affected, or something's wrong with the motor unit itself. And sensation, usually there's a proprioceptive defect or a vestibulocochlear reflex is abnormal. But as we saw in our physical exam, the child examined pretty normally for sensation. So I'm going to take that off. Cerebellum, could the child have intention tremors? Yeah, we saw the tremors, the hypotonia, the ataxia. Yeah, that could fit. I'm going to keep cerebellum on the list. Basal ganglia, we don't have any rigidity. We don't have dystonia. We don't have any choreiform movement, so I'm going to take that off. How about the motor unit? We'll go from the upper motor neuron all the way down to the muscle. Upper motor neuron, usually spasticity and brisk deep tendon reflexes. That doesn't sound like our child. Anterior horn cells, hypotonia, and absent deep tendon reflexes. That's not the picture that we see, so I'm taking that off. Peripheral nerves, usually you have some sensory component to it, and as we said already, the sensation is normal, so I'm going to take that off. Neuromuscular junction, usually diurnal pattern, and worse later in the day, fatigable weakness, and we don't get that history, so I'm taking that off. But how about muscle? Well, muscle usually have proximal weakness, so a muscular dystrophy, and the weakness is earlier on is disproportionate to the atrophy. So maybe there's early onset of a muscular dystrophy. So in terms of regression in motor function, you got cerebellum and muscle. This is the list I developed for cerebellar defects that can cause gross motor regression. I said that list is long and lots of things are on there that I have no idea what they are. So I said, how am I going to whittle this down? Well, let's look at the blood work again. What we do see is, for a 14-month-old, we have to take into account that the reference values of your blood, your biochemistry is going to change a little bit. So taking that into account, things are pretty normal, except for the platelets, the AST and ALT are maybe minimally elevated, and ALP is kind of low. But otherwise, biochemically quite normal. There's no acidosis, electrolytes are fine. So when I go back to this list, I can say, all these things here are inborn errors of metabolism, usually cause an acidosis and is episodic in nature. That doesn't fit. Friedreich's ataxia doesn't fit. Lipoproteinemia doesn't really fit with the presentation of our child, but maybe there's a vitamin deficiency that I don't know of. So I'm going to keep that on because that could be a systemic illness. Wilson's disease, copper toxicity, yeah, maybe it's a heavy metal. It's on my list. I'm going to keep that on. Rett syndrome usually is normal development and then regression in motor, which is the classical story, but they usually don't have dermatological or oral manifestations, so I'm going to take that one off. How about muscle? Well, dystrophies, most of them are X-linked, and when Dave gave the case to me, it was a female. So X-linked disorders are unlikely, so I'm going to take those off. And the limb-girdle muscular dystrophies are usually oral. They don't have oral or dermatologic manifestations, so I'm going to take that off too. All right, so I went through a bunch of things. At the end of the day, all I have is vitamin E deficiency and Wilson disease. And at this point, I said, I really suck at CPCs, but I kept going. So let's look at the next one. So swollen gums or gingivostomatitis. I'm going to use the vitamin C, D, E structure, so I make sure I capture everything here. Vascular causes. Behçet doesn't fit, but Kawasaki's disease definitely has the inflammation and the involvement of the palms and soles, so we'll look at that a little bit more closely. Infectious diseases, for sure. We'll go into that a little bit more closely later on. There's no traumatic history that we have, but heavy metals are known to cause gingivostomatitis, multiple ones. Thallium, mercury, and arsenic being the ones that I came up with. Autoimmune, there's a lot of autoimmune diseases that can cause gingivostomatitis, but just take my word for it, as I looked into it, a lot of these don't really fit the other manifestations that this child came in with. Metabolic, vitamin C deficiency. Oh, maybe it's vitamin C deficiency. That's going to lead me down. I should probably look at all the other vitamins that might cause this symptomatology. There's no history of ingestions of any medications. But however, as I looked at this case, I said, oh, gold, another heavy metal. Maybe heavy metals is something I need to look into a little bit more closely. Neoplastic doesn't really fit. Coagulation disorders, INR, PTT were normal. Platelets. Platelet disorders don't usually have the dermatologic and oral manifestations that this child had. And a 14-year-old with degenerative disease is unlikely. So I'm going to take those things off. Okay, so let's look at infectious. Like Meg, I split it up into bacterial, fungal, and viral. There's a bunch of things that can cause gingival stomatitis, but a lot of them don't fit. Maybe TB. TB can be a lot of things, as Meg alluded to already. Toxic shock syndrome can cause the desquamation, the erythrodema. So let's keep those on. Viral, maybe Coxsackie with the hand, foot, and mouth disease, but a lot of the other ones don't fit. How about fungal? You know, blastomycosis, as Meg had talked to you about before, is usually pulmonary manifestations, and our child didn't have any of those. And the other ones usually are in a patient that's immunocompromised, and we don't see that in our child. So we're going to take those off the list. All right, so my differential is getting a little bit bigger. Let's cross-reference it with another one. Let's use the last one here, the erythema to the hands and feet, desquamation of the palms and soles. What differential do we get there? Well, we got Kawasaki disease coming up again. Scalded skin syndrome doesn't really make sense. There's no bullae. Toxic shock is there again. Coxsackie is there again. Group A strep doesn't really make sense for our case, but Rocky Mountain spotted fever with the palms and soles, maybe. Mercury toxicity comes up again. These autoimmune causes don't fit the other manifestations of our disease. And many other things are not fitting our case. So at the end, after looking at all those parts of the signs and symptoms, I came up with this differential diagnosis. And when I looked at it, I said, it's still too big. I don't want to look into all these things. So can I take something off the list? Well, TB is on the list, but you know, our child is from Arva and then moved to Timmins. In Canada, it's unlikely that there's no history that she was in a First Nations community or in a reserve, which unfortunately has a higher incidence of tuberculosis. Usually TB's cutaneous manifestations are nodular and very, very focal, so it doesn't really fit. So I'm going to take that off. Coxsackie, hand, foot, mouth. The rash is a little different. It's not the erythroderma. It's usually vesicular. So it's not really fitting that pattern, so I'm going to take that one off. How about all these vitamins? Okay, well, let's quickly look at the vitamins. I split it up into oral, skin, and neurological manifestations and see which ones would maybe cause the symptomatology that we see. For the fat-soluble vitamins, for A, D, and K, E and K, vitamin K maybe has manifestations in all of those categories, but it doesn't really fit as a coagulation disorder. How about the water-soluble vitamins? Well, for all of them, maybe vitamin C. You can get the bleeding gums, you can get hyperkeratosis, and maybe that was what they thought was the desquamation, and you can get weakness. Okay, so maybe vitamin C. So I'm crossing a few things off the list, but I'm still left with all these heavy metals, and I don't want to look into all of them. So here is a summary of the heavy metals that I saw, and again, cross-reference to all of the symptomatology categories that we have in our case. And the only one that really makes sense would be mercury. And they can have that gingival stomatitis, you can have involvement of the palms and soles, you can have erythrodema, and you can have tremors and irritability. But usually you have proteinuria, so that's not really fitting our case. But all the other things make sense, so I'm going to keep it on to take a look at it a little bit further. So I crossed off a bunch of things, and I think I've come up with a manageable list. And there are these 5 things. Okay, so toxic shock. Toxic shock syndrome is caused by toxin, entero, or exotoxins produced by staph and strep. And you can have that desquamation of the palms and soles, as seen here, and you can also have the erythroderma. That being said, there are strict diagnostic criteria for toxic shock syndrome. So let's see if our kid meets any of them. We know that our child has diffuse macular erythrodema. There's desquamation of the palms and soles. and there's some mucous membrane involvement. But child doesn't have fever. Child's definitely not in shock. It's hypertensive. I know blood pressure doesn't mean shock, but there's no major criteria in terms of the fever and the hypotension, and doesn't have 3 or more of those organ systems. So although there's some similar manifestations, it doesn't fit the criteria, so I'm going to take that off. How about Rocky Mountain spotted fever? Rocky Mountain spotted fever is caused by these bad boys, Rickettsia rickettsii, gram-negative intracellular bacterium that have a tropism for the vascular cells, endothelial cells. Vector is ticks, and the rash kind of looks like this. Fever, headache, abdominal pain, and then the rash 3 or 5 days after. And when you look at this rash and the one that was described, it's not really fitting. It wasn't a macular on top of an erythematous base. It was just erythema everywhere. And there's no history of tick bite. I know you don't have to have a definite tick bite to have Rocky Mountain spotted fever. But RMSF doesn't have desquamation and the oral ulcerations that we see in this case either. So I'm going to take that off the list. All right. How about vitamin C? Well, after looking into vitamin C just briefly, it doesn't really fit either. The oral manifestations and the cutaneous manifestations aren't really consistent. The rash is a lot more perifollicular and very discrete, rather than that blanching whole body macular papular rash and then affecting the palms and soles. So I'm going to take vitamin C off the list too. All right, I'm left with Kawasaki. Kawasaki, as we all know, is a vasculitis of unknown etiology. Usually affects the medium-sized arteries and coronary arteries especially. And it's caused by inflammatory cell infiltration into the vascular tissue, causing dilatation and aneurysm. And the clinical manifestations are like this. They got the fever, they have conjunctivitis, erythema of the mucositis, the rash, extremity changes, they can have lymphadenopathy, and they have irritability, weakness, and decreased oral intake. So it could be Kawasaki. But Kawasaki, again, has strict diagnostic criteria. You have to have a fever greater than 5 days. And in our case, they said, oh, it's an intermittent fever, was never really taken and shown to be febrile. So was there actually a 5-day history of fever? I'm not too sure. And you have 4 of the following. Our child has maybe 3, the mucositis, the rash, and the desquamation. But there is something called atypical Kawasaki or incomplete Kawasaki. So where you have fever and 2 or 3 of the minor criteria. So yeah, it definitely could be atypical Kawasaki. So I'm going to leave it on the list. The last is mercury toxicity. And mercury toxicity, Meg talked about it a little bit, but it depends on the type of mercury that you're exposed to. You're going to get a different toxic presentation. Now I'll talk about the elemental mercury first. And that's usually involves inhalation of mercury vapor, and kind of presents as the Mad Hatter did. If it's acute, then you can present with an ARDS-like picture. But usually if it's a subacute or chronic exposure to mercury vapor, then you get intention tremor, you get the gingival stomatitis, and you get that neurological changes in terms of excitability, irritation, and shyness, which our child also had. But there's something particular about elemental mercury, and that's with kids. Kids have been shown to develop what's called acrodynia, and it's a hypersensitivity to mercury. It was very common back in the 40s when they used to use teething powders that had mercury in them, and kids would present with the clinical manifestations as I've listed here: the body rash, swelling, desquamation, irritability, photophobia, fever, and the profuse sweating. And so maybe it's a inhalational mercury exposure. That's possible. When I first got the case, I was like, okay, maybe they're up north in the cottage, they're eating more game fish, there's more methylmercury, organic mercury. Maybe that's where they're getting their mercury toxicity from. But to be honest, the syndrome that you get with organic mercury is more perioral anesthesia or paresthesia, malaise, ataxia. You don't get the cutaneous manifestations that this child has. So it made a lot less sense to be organic mercury. So at the end of the day, I'm left with a typical Kawasaki or acridina. And I looked at these pictures, and I was like, man, they look exactly the same. How am I going to decide between the two? Well, I think fever is one of the main things. There's not a definite history of fever more than 5 days, greater than 38.5 usually for the Kawasaki's. So it's making it less likely. But if I'm saying it's not a typical Kawasaki, then I'm saying it's acridina. And I don't really have a good exposure for mercury. How's this kid going to get mercury? And why is it in a cottage? And why is it in Timmins? And all these questions started coming through my mind. But there's one thing that really helped me, and it was that Dave said, after some thought, I would get a single investigation and already know what it is. Now, I can't diagnose Kawasaki's with a single investigation, so by default, it has to be acridina. But I still need to, I wasn't satisfied. I had to, how is this kid going to get mercury toxicity? Well, we all know that kids spend a lot of time on the ground, and they're always playing near the ground and everything like that. And there's multiple reports of kids being exposed to mercury that's been in the carpet, that's been spilled there accidentally, whether by parents bringing it home from where they work, if they're an electrician or a pipe fitter. A lot of the switches have mercury in them, and it can spill on the carpet, and it can stay there for long periods of time. And the mercury, as it vaporizes, the vapor is heavy, so it stays low to the ground. So all the kids are going to get exposed, but the parents who are upright aren't going to get exposed. And there's multiple reports of families moving into houses, the kids getting sick, and then they find that the previous owner had spilled mercury into the ground, into the carpet. So I'm saying, oh, this is maybe more plausible. Maybe that happened, but why in this cottage? Who's going to spill mercury in this new cottage in Timmins, Ontario? Well, what's so special about Timmins, Ontario? Well, many things, but gold is particular about Timmins, Ontario, and mercury is used to purify gold. So maybe this person was a jeweler and was using mercury to purify gold in their house. Maybe the previous owner was an amateur prospector going out trying to find gold ore and trying to purify in their home. Or maybe this person said, I want to get rich with gold, but didn't want to go out and prospect, so they said, I'm just going to be an alchemist and use mercury and try to create gold on my own. So, I have no idea what this person was doing, but I'm pretty sure that there was mercury in the carpet. The family moved in, and the child developed acridina. So I'm going to order a 24-hour urine collection for mercury, and I'm going to diagnose acridina. And that's my final diagnosis.
Okay, well, I know we're a little over time, but that was a great job, and it indeed was mercury poisoning for all the reasons that he pointed out. So, great job. So, I don't know if I could have come up with that. That's why I put out the cases. You guys do them, because I wouldn't want to do it. But hopefully everyone enjoyed themselves. This case was a real case. Got it when I was on, I didn't deal with the exact case, but got it when I was on the Poison Control Center. Apparently, these people moved into a cottage in Timmins. The previous owner was an alchemist in the Timmins area, and there's mercury all over the cottage, and how would you know? With all the excessive vacuuming that the person did cleaning up their new cottage, there was lots of heavy mercury vapor. Well, it was only the small child of the other kids and the family that was exposed. So it came into the emerge multiple times, and my understanding was the only person who picked this up was this very old school doctor who, I don't know, was 200 years old, but and had seen it before and walked in and said, yeah, that looks like Pink's disease. That looks like acridina. That's probably what it is. And so they called the Poison Control Center, but nobody had heard of this in a while, and it's a disease of the 40s and 50s, but he ended up picking up, calling Poison Control, and then that's how it was discovered. And it was discovered with the 24-hour urine. So great job. Great job, Meg. I won't keep you here. Just come sign up for dinner and lunch for Kovacs, and come next week to rounds. Hello, Chris. Meg. Really amazing cases to you.
Oh, please, man.
This case sounds hard.
Oh, thanks, man. Yeah.